Great, thank you, June. Apologize for the alarm in the background. One of the hazards of Zoom meetings, right? Really great discussion. I think data, as we talked about yesterday at the QI workshop, data informs everything we do. And in this next section that Dr. Charlotta Guillory will be moderating, we're going to look at how do we incorporate health equity lens into our quality improvement projects so that we can truly address those racial ethnic disparities that we've observed. So I'd like to introduce Dr. Guillory. She's the co-chair for the neonatal committee of the Texas Collaborative for Healthy Mothers and Babies. She's an associate professor of pediatrics in the section of neonatology at the Baylor College of Medicine and the director of the Texas Children's Hospital Neonatal Perinatal Public Health Program. She received her postdoctoral fellowship training in neonatal perinatal medicine at the Baylor College of Medicine, and she's board certified in both pediatrics and neonatal perinatal medicine. In addition, she serves on the Texas Health and Human Services Perinatal Advisory Council, designating levels of neonatal and maternal care. Dr. Guillory was recently appointed to the AAP National Committee for Fetus and Newborn and is the president-elect for the Texas Pediatric Society in 2021. Welcome, Dr. Guillory. Maybe.
Thank you very much, Dr. Ramsey, for that introduction. And good afternoon. It is now my pleasure to introduce the next speaker for this session, Dr. Dwayne Persley, speaking on incorporating health equity lens into quality improvement projects to address racial and ethnic disparities. Dr. Persley is chief of the Department of Neonatology and director of the Family NICU at Beth Israel Deaconess Medical Center. He is an associate professor of pediatrics at Harvard Medical School and associate clinical chief of the Boston Children's Hospital Division of Newborn Medicine. Dr. Persley earned his medical degree at Harvard Medical School, completed his neonatal perinatal fellowship in the Harvard system, and earned a Master's of Public Health in Health Policy and Management at the Harvard T.H. Chan School of Public Health. A member of the American Pediatric Society, his scholarship and clinical work has focused on NICU performance improvement, resource utilization, and in neonatal health equity, recently publishing in Pediatric Research, The Color of Health, How Racism, Segregation, and Inequality Affects the Health and Well-Being of Preterm Infants and Their Families. Dr. Persley has published numerous articles, over 150 at least, and received numerous awards. He has served as chair of the AAP Neonatal Perinatal Medicine section and chair of the American Academy of Pediatrics Board of Directors Diversity and Inclusion Task Force. He continues to work tirelessly to improve the outcomes of mothers and babies. I give to you, Dr. Persley.
Thanks, Dr. Guillory. It's a real pleasure for me to have been invited to participate in this amazing program. I'm so impressed by your collaborative. I checked in on some of the race equity and QI health equity training programming yesterday, and it was really outstanding. Next slide, please. I have no relationships to disclose relevant to this topic. Next slide. So this could be the topic of a full day workshop, maybe even a couple of days, and I'm happy not to replicate the really excellent QI equity overview that was provided by Drs. Wagner, Davidson, Epps, and Ramsey from yesterday. So today I'll focus on the following areas. I'll focus primarily on reviewing the recent evidence relating to health equity and quality improvement in newborn care. Much has been published over the last 4 to 5 years, and it's really worthy of review. And I'll identify some strategies to incorporate health equity into our QI projects. Here, I'm going to focus on change strategies. Here, I'll also focus particularly on family engagement, which is an area a bit less evolved from our usual suite of process and outcome measures. And and if time permits, identify at least a couple of ways in which a couple of different groups have monitored, measured, analyzed, and provided reporting on health disparities in a clinical setting. Next slide. So what do we know? Next slide, please. We've witnessed an impressive trend in infant mortality in this country. In 2018, overall, it declined 2% from the previous year to 5.67 deaths per 1,000 live births. This is the continuation of a long trend with rare exception of infant mortality reduction in our country. The decline in infant mortality in this country is one of the most dramatic declines in mortality ever recorded. It is halved every 25 to 30 years. That's really remarkable. Next slide. We know that infant rates vary geographically within the country. When we see variability intuitively, we see this as an opportunity to improve. Earlier this afternoon, the March of Dimes report grade for Texas was demonstrated. In Massachusetts, our infant mortality rate is a little lower, and there are some racial and ethnic reasons for that. But nevertheless, there is much opportunity. In fact, in all US states, there's opportunity for improvement. Next slide. We recognize that race and ethnicity are significant contributors to infant mortality, and that can blunt our optimism regarding the opportunities for improvement. After all, one can't modify one's race or ethnicity. We can recognize that distribution of race and ethnicity in our states is a major contributor to those interstate differences that we see. Next slide, please. We know that infant mortality declines can be affected by two major factors: reductions in gestational age distribution, that is, fewer babies are born at gestational ages with high mortality risk, and reductions in gestational age specific mortality, that is, fewer babies dying at gestational ages with higher mortality risk. So reducing preterm birth or providing better care to either improve the condition of the baby at birth or improving the care provided to the newborn are the major opportunities to reduce infant mortality and infant mortality risk for short and long-term morbidity. Next paragraph, next slide, please. We know that preterm birth rates actually increased 2% in 2019. They were higher for both Black and Hispanic mothers relative to their white counterparts. The elevated rates persist for both early and late preterm gestational ages. So excess prematurity in both the early and late phases contribute to prematurity. Although there is significant improvement years ago in late preterm delivery rates with the elective delivery guidelines, historically early preterm rates have been difficult to move, particularly in the early phases where mortality is much higher and substantial disparity exists. Next slide, please. Even though babies born early preterm are more likely to die than those who are born late preterm, you have to account for the fact that there are a lot more late preterms delivered compared to their early counterparts. So how does each gestational age contribute to infant mortality? You can see here in these slides, excuse me. So over the 7-year period in this analysis, you can see gestational age category in the first column, followed by total population, and then non-Hispanic white, non-Hispanic Black, and Hispanic percentages. The absolute decrease in infant mortality rate is at the bottom. So there's a 14% overall reduction in infant mortality, and that was greatest for non-Hispanic Black women. There was a reduction in the contribution of gestational age to infant mortality occurring for each racial and ethnic category of almost every gestational age. The exception here was the exception of non-Hispanic white women at 32 to 33 weeks. The distribution in gestational age rate reduction differs by racial and ethnic category. Non-Hispanic Black women here were actually the primary beneficiaries at early preterm, and non-Hispanic women benefited at early term. Next slide, please. For all babies, these reductions in infant mortality have occurred primarily because of reductions in gestational age specific mortality. That is, babies are dying at lower rates. In this chart, 69% of the infant mortality reduction was attributed to gestational age specific mortality. The GA specific mortality reduction occurred at the same rate for non-Hispanic Black infants and was even higher for Hispanic infants. So taken together, this data suggests that NICUs continue to play a key role, not only in infant mortality reductions, but also in the reduction of infant mortality racial disparities. NICUs have a really important role in both reducing mortality as well as reducing racial disparities in mortality. Next slide, please. So our community has contributed substantially to the health equity literature in the last 5 years. I really think it's useful to review some of this recent evidence. Next slide, please. Liz Howe, who's an obstetric colleague, looked at morbidity and mortality for more than 7,000 very preterm infants born in New York City hospitals and documented substantial variation in the risk-adjusted neonatal mortality and significant morbidity. That is BPD, severe NEC, grade 3 or higher ROP, and grade 3 or higher IVH. And these mortality is looked at by hospitals, and these are the hospitals by rank. Where a baby was born seemed to make a big difference. Next slide. Here, race and ethnicity is in the first column, followed by data on low, middle, and high morbidity and mortality hospitals. Now here, focus on the distribution of race and ethnicity in the last grouping. Looking at the distribution of births across the racial and ethnic categories, you can see that non-Hispanic Black and Hispanic infants were more likely than non-Hispanic infants to be born in hospitals with the highest risk standardized rates of morbidity and mortality. And this is represented in the last column category. There are substantial differences in outcomes within the hospitals, but the differences in hospital birth explain 40% of the Black-white disparity and 30% of the Hispanic-white disparity in outcomes. So it appears like several maternal measures that outcome disparities exist both within and between hospitals. What are the factors that explain these differences? Next slide, please. Several large clinical databases like Vaughan have provided more, that's the Vermont-Oxford network, have provided more insight into the outcomes and specific practices that might explain these differences in morbidity and mortality. In this study, using data from the California Perinatal Quality Collaborative, the Monitor tool is used. The Monitor tool examines 9 processes and outcomes reflected in that list overlying the chart in the right lower corner here. And in this study, they looked at 135 California NICUs, and Jochen Profit was able to demonstrate significant racial and ethnic variation in care quality. Here, higher scores are better. The blue dots are non-Hispanic white and the red dots are non-Hispanic Black. Again, this occurred both between and within NICUs. Next slide, please. Relative to white infants, Black and Hispanic infants scored lower on these practice and potentially modifiable outcomes. Here's a plot looking at differences between Hispanic and white infants for the Monitor subcomponents. In this example, Hispanic infants were less likely to be receiving human milk at discharge, to have benefited from antenatal steroids, to have received timely eye exams, to avoid hospital-acquired infection, and to exhibit high growth velocity. Next slide, please. Also, using the Vaughan data set and a cohort of more than 200,000 infants who were born between 22 and 29 weeks, and this was over 12 years, Boghossian demonstrated a decrease over time in racial and ethnic disparities in several care practices and outcomes. These are outcomes with with Black patients depicted in red and Hispanic patients in black, in blue, relative to the majority population, and that's depicted by the dotted line. Compared with white infants, African American infants had a faster decline for mortality, hypothermia, necrotizing enterocolitis, and late onset sepsis, whereas Hispanic infants had a faster decline for mortality, RDS, and pneumothorax. So given the improvements for several care practice measures and potentially modifiable outcomes, this reinforces our belief that quality improvement initiatives targeted at the disparate practices are effective and important. Next slide, please. Jeffrey Horbar and colleagues sought to determine the extent of segregation in the care of very low birth weight and very preterm infants across more than 700 US NICUs over 3 years, again using monitor scores. Segregation here is the uneven distribution of race and ethnicity across NICUs. And inequality is the concentration of racial and ethnic groups in lower quality NICUs. Frankly, these Lorenz curves make me a little dizzy, but they examine race and ethnicity in US NICUs ranked by the proportion of white infants from highest to lowest. And the cumulative population percentages of white and minority infants are plotted here. Basically, if all the NICUs had the same racial or quality distribution as the overall population, the curves would fall on the same diagonal dotted line. And the fact that they don't indicates that NICUs are segregated by race and ethnicity. NICUs are segregated by race and ethnicity. Kind of mirrors our society, doesn't it? Next slide, please. Here's the bottom line. So there's evidence for this, as we've already seen in New York City and in California, and now we have evidence for it in over 700 NICUs in the country. Compared with white infants, Black infants were concentrated at lower quality NICUs. Interestingly, Hispanic and Asian infants were concentrated at higher quality NICUs. These columns looking at NICUs with 5 levels of monitor scores, from those with the highest score on the left to those with the lowest scores on the right. The highest quality on the left, the lowest quality on the right, and you can demonstrate here that Black infants are more prevalent in those lower quality NICUs. So segregation explains where infants receive care, but not why Black infants receive care at lower quality NICUs. What are the social demographic factors and public policies that affect hospital quality, access, and choice for minority women and their infants? So herein lies the concern of residential segregation in the US that results from structural racism. There are many effects. There's economic well-being, education, health, healthcare, and many others. The roles of racism and bias in healthcare inequality deserves a lot of investigation, and we're only getting started. Next slide, please. So we gained substantial insight into some of the struggles encountered by racial and ethnic minority NICU families through accounts that were captured in Krista Sigurdsson's qualitative study. In this study, she describes and characterizes disparities in NICU quality of care through narrative accounts of family advocates and clinicians at a national quality conference meeting. The clinicians included nurses, physicians, nurse practitioners, and many others. Here you see examples of suboptimal care described, and those are broadly described as neglectful care, judgmental care, and systematic barriers. Think about these for a bit. Can you envision these behaviors in your own unit? You know, I can. I'm guessing that we can also relate to the privileged care example. All of our patients should receive privileged care. You should note that language barriers will cut across and impact all of these different types of disparate care. And we also often see, isolation, delayed care, misuse of and inadequate translation services for patients who are not English language proficient. Regrettably, the accounts included lack of empathy for opioid-dependent mothers or absentee families, lack of accommodation for cultural needs, overt racist treatment of families of color. Some were assumed to be violent, difficult, or at fault for their life circumstances, as opposed to majority families who are given a bit of leeway in displaying a variety of emotions and behaviors. So disparate care can be experienced by families as well as infants. The accounts suggest that families' racial and ethnic, social, financial, cultural, linguistic, and other characteristics may influence interactions with NICU providers, and that the care of their infants may suffer as a result. Next slide, please. So now you've seen several studies documenting racial and ethnic disparities in NICU care. Dr. Signason also helped us by pulling some of these studies together in a systematic review of the literature that documented racial and ethnic disparities in quality of care for babies in the NICU setting. And her team reviewed more than 400 abstracts and distilled those down to about 40 articles that met the predefined criteria and identifying disparities in one of these three categories of measures. So structure, among other factors, it emphasizes the critical role of nursing culture. Research from the Vermont-Oxford Network has found that nurse-patient ratios, nurse work environments make a difference, as do higher rates of missed nursing care, recognition for nursing excellence, that is magnet status in this case. Process. This includes several practices and actions that potentially relate directly or indirectly to improved outcomes. Breast milk is associated with reduced neck rates, of course. Surfactant and non-invasive respiratory support may help reduce respiratory morbidity. Kangaroo care, shared decision-making, and family experience may affect discharge readiness and the confidence and competence that is needed to provide optimal care of their babies post-discharge. Outcomes, a whole host of disparate outcomes have been documented in the literature, including NEC, IVH, hospital-acquired infections, mortality, respiratory conditions, and several more. Next slide, please. So there are a whole host of potential opportunities to reduce disparate care and outcomes. These are outcomes that generally disadvantage infants of color. Given the studies that we've reviewed, they may reflect differential quality of care or differential access to high quality care. Different disparities may require different strategies. If we standardize practices and consistently apply them, we should observe differences in the outcomes area. It's also true for many of the process measures. Parental satisfaction and family experience and shared parent-provider decision-making are important factors to address. Doing these well can help ensure uptake of other practices. Next slide. So this is where we are. And NICUs continue to play a key role not only in infant mortality reduction, but also in the reduction of infant mortality and racial and ethnic disparities. There are persisting racial and ethnic structural process and outcome differences that reflect and affect differential morbidity and mortality. Racial and ethnic disparities are seen both within and between hospitals, and there's evidence of inequitable care toward families that may in turn affect the care and outcomes of their infants. Next slide. And then the next slide. So here's a starter list. How do we bring this discovery and knowledge to our daily practice? Apart from the difficult work of advancing diversity for our units, what strategy might we employ? Here's a starting list. Rejecting notions that marginalized populations are inherently advantaged or disadvantaged. Outcomes largely aren't predetermined, but are potentially modifiable. either directly or indirectly. They're potentially modifiable by what we do. Get rid of these biological difference assumptions, including equity as care quality factor, similar to other quality domains. You know, we look at safety, we look at effectiveness, we look at timeliness. You know, we should pay equal attention to equity. Consider intervention quality as well as presence. You can look at timeliness, like for surfactant or antibiotics, or comprehensiveness, like in social determinant of health screening. Include balancing measures when they're relevant. In our zeal to avoid hypothermia, let's make sure that we don't overheat them. Examine sustainability of effects. In our Massachusetts Quality Collaborative Project, Meg Parker showed that there were no racial and ethnic differences in breast milk use initially, but it wasn't sustained until discharge. Establish family care standards and develop measures to track compliance. Identify outcomes as well as processes in family engagement. It's great to track family meetings, whether they occur or not, how often they occur, but there are other opportunities. Here in our hospital, we're using a survey tool to look at several domains: confidence, continuity, coordination, environment, information, participation, support, and overall impression of family support. We also look at discharge readiness. Ensure diverse representation on family advisory groups. Give families of color a choice in formulating, a voice in formulating NICU policy. Ensure that infants within systems are receiving risk-appropriate care. Now, this shouldn't be much of an issue there in Texas, where you've developed and promulgated. I see Dr. Spear, Dr. Guillory, Dr. Savani there among the participants, and there are many others of you who were involved in developing this Texas standards. And these standards are quite important, as well as the incentives that you have in Texas to ensure risk-appropriate care. Next slide, please. So could the factors relating to families in part account for the findings in this study here? You saw this earlier in Wanda Barfield's study. It primarily, most of this work is focused on outpatient adult care, and it emphasizes the benefits of patient-physician concordance on clinical care outcomes for underrepresented minorities. And the argument is that it can ameliorate biases, it can improve communication, and increase trust. And in this study, they examined a couple million hospital births in Florida over a 24-year period and found that newborn physician racial concordance was associated with a significant survival advantage for Black infants. The results also suggested that these benefits really were manifest as well during the more challenging births and in hospitals that deliver more Black babies. Really interesting results that need further exploration. But perhaps there are some really substantive benefits in diversifying our workforce. Next slide. I'm sure Henry Lee will get more into this, but CPQCC has suggested 10 ideas in these categories to improve family-centered care for diverse families. They range from ways to establish an equity cultural norm in the unit, acculturating families to family-centered care, improving family communication, conducting assessments of family unmet needs, invoking strategies to improve family leadership, and developing targeted family education. And you can find this very easily on the internet. Next slide. The hope is that this high-level family engagement will assist in our ability to address the potential factors underlying these disparities in the hospital and beyond. Next slide, please. All of those factors are associated with poverty, effects that impact our families while in our NICUs and have significant effects on the growth and future development of our graduates. The NICU offers many opportunities to start to mitigate some of these effects early in the life of these vulnerable infants and hopefully alter their life trajectories. There's a lot of work to be done in this area. Meg Parker offers suggestions on how we can best assist impoverished families in our NICUs, addressing short-term needs through universal programs. This looks at basic needs that can result in added stress and anxieties for our families with NICU babies, including food, parking, and transportation, childcare, and mental health support. Use of screening tools for longer-term unmet needs. These are challenging, but they're even more challenging and they rely on screening tools administered by the NICU and hospital staff, and community partnerships are really essential for these potential interventions. So to be effective, an awareness of community program offerings is really critical. Family navigation of social services. Social workers, case managers are generally fully committed to the mental health assessments and the social supports, the home supports for infants that we're going to be discharging with special healthcare needs and other more immediate needs. Peer support has been effective in some models to assist with navigation. Mental health support. There's no standard for NICU screening, but surveillance for NICU-related stress and anxiety, as well as for postpartum depression, is important. Coordination of efforts with high-risk infant follow-up programs. Again, there's currently no formal standard. The AAP Committee on Fetus and Newborn is currently reviewing this need, including Dr. Guillory. And I can anticipate that there'll likely be a policy statement in the near future. There's variable access to these services, and access can be difficult. And this is certainly true in Texas, and especially given the geography. Next slide, please. So social determinant health screening has been commonly employed in the pediatric outpatient setting. In this study, Meg Parker used a mixed method study in 2 safety net NICUs to determine how often unmet needs are assessed and identified among NICU families. And they found that apart from employment, other unmet needs were infrequently assessed. And these included housing, food and hunger, childcare, transportation, and the reliability of utilities. In their focus groups, the staff concluded that processes to assess social determinants of health weren't standardized and were inconsistently performed and documented in addressing, and this is critically important in addressing social determinants of health. And they recommended using a standardized screening and referral process. Next slide, please. In a commentary in the journal Pediatrics, Jeff Horbard, Eric Edwards, and Yolanda Ogbulu brought attention to the social determinant of health challenges confronted by our babies and families. And they highlight the need to practice social as well as technical medicine and to accept some responsibility for our infants and families beyond our hospital walls after discharge. They propose the term follow-through to distinguish this support from follow-up that's focused on medical conditions and neurodevelopmental assessments. And there are 3 more major categories on the next slide. They provide these 6 general categories as examples of potentially better practices for follow-through. Next slide, please. Finally, in the appendix of our article, The Color of Health, we provide several more. There's a total list of 62 that are organized along the same outline structure. So there are many opportunities to improve care in the NICU. While we work to improve the technical aspects of care, let's also focus on how we provide the care, support our families, and prepare them for discharge and beyond. Next slide. And then the next slide. I've included a couple of slides here to show how a couple of groups are analyzing and displaying their data. And some are using simple run charts. This is an example of how measurement can be reported through an equity dashboard. Here they're reporting on year-to-date performance on in the demographic with the highest number of impacted or missed patients. And that could be Hispanic patients, patients with preferred language other than English, and other categories. They look at quarterly trends, they look at annual trend, and annual change in the disparity of choice and the number of missed opportunities. So you can get a lot of information in one screen. And then the last slide, please. Statistical process control, these time series, the shifts here using control charts and adjusted relative risk can be done as well. This is work that was, I think, previously shown this afternoon, involving work by the Hemorrhage Quality Collaborative at CMQCC in California. And next slide. So this quote clearly looks familiar to you by now. I think I've seen it 3 or 4 times over the last couple of days. It's often cited, particularly in talks about racial and ethnic disparities, but I'll point out that it's often misstated. And in fact, I was impressed that Wanda actually had the actual quote. It's usually stated as of all the forms of inequality, injustice in healthcare is the most shocking and inhumane, healthcare. But Dr. King actually referred to the more holistic concept of health, not healthcare. All of us are engaged in healthcare, but our goal is to optimize health and the well-being of our babies. We need as much as possible to extend ourselves for that to occur. And we need to extend our support to families. And we need to do what we can to send them from the hospital and then beyond the hospital walls with the best chance of achieving the optimal goal. Thank you.
Thank you very much, Dr. Pursley, for this very informative presentation. We do have a few questions from the audience. The first one is racial ethnic disparities are not new issues. In the current social climate, and as the mainstream has become more aware of this important issue, how do we sustain the momentum so that these quality improvement projects actually lead to decreased racial ethnic inequalities?
That's a really great question. And I would say that the way we look at equity really shouldn't differ from the way we look at other quality measures. I think we need to continue to be vigilant, to collect the data, to track the data. It may get monotonous at some point, and we don't necessarily need to share it publicly if it achieves that status, but nevertheless, the leadership, the quality leadership needs to ensure that they're tracking that data. I also think that there's a lot of work to be done in promoting an equity culture in our units. And I think if we all sort of share the same mindset and the same commitment to ensure that our babies and our families are receiving equitable care, the opportunities to look for new the efforts to look for new opportunities to pursue care, the questions that we ask to determine whether or not these disparities may exist, I think will be enhanced.
Thank you. The second question is, for those of us participating in this conference, what is the one action that you propose that each of us can do today to really make an impact on racial ethnic inequalities, caring as we care for our patients? The one thing they should take away from your talk today.
At your next quality meeting, if you haven't done it yet, choose an equity measure. Find something. And there are examples, as I've shown, there are multiple examples of those in the literature. There's a fair amount of data on breast milk use. And I think breast milk use is a great place to start because it is modifiable. It has potential impact on outcome, particularly in small babies, but in larger babies as well, given the outcomes associated with breastfeeding. And it really requires strong family engagement. And that will help sort of lead to some discussions about how we can better engage families to traverse some of the barriers that we have in our NICUs, to working with them in effective ways to ensure translation capabilities are fully accessible to our families. So start at your next meeting, start right away, find one measure to follow, and the rest will come.
Thank you. Just to mention, in one of our projects that we did on breastfeeding at the time of discharge, we actually were able to work with WIC to provide breastfeeding pumps for our mothers before they left the hospital. A very small intervention, but really made a big difference in improving breast milk feeding for our babies at the time of discharge. The third question I really want to get to is, how much of a role do you feel the insurance system plays in the lower infant mortality rate, the lower prematurity rate in Massachusetts compared to like, for example, Texas?
Ooh, that's a really interesting question. As Dr. Guillory is aware, I've been involved with the AAP NICU verification program. So I've had the opportunity to actually review on site, maybe at this point, a couple of dozen NICUs. And I think, the quality improvement work that you're doing, the QAPI work and the RACs are really important vehicles for ensuring the care within the NICU. I know less about the access to care. I think insurance coverage in Massachusetts provides coverage for all pregnant women. And I don't know how that compares to what you have in Texas right now. But in terms of access, insurance coverage is really critical. Insurance in Massachusetts will also cover breast pumps. So, finding, they're both, I imagine, kind of these material needs as well as access needs that insurance coverage is really critical for. But I'm less aware on the policy end and the of what sort of types of disparate coverage might exist in Texas. I'm sorry.
Because you actually have done so much, Dr. Pursley, I actually had and wanted to say that you do work on the AAP steering committee in the NICU verification program. And as a result of that, it was critical in Texas really developing levels of care here. So thank you very much for that work.
Texas is in its second cycle now. And, anecdotally and talking to other reviewers, it's been impressive how much improvement has been seen from the first to the second. This is really, I don't know if you're aware of how exceptional that code is and how there's a real need for that to be distributed to other states around the country, where you can basically hang a sign outside of your NICU stating the intent of the level of care you intend to provide. Texas is really leading the country in this area, and we're hopeful that will be replicated in other states.
Okay. Thank you so very much, Dr. Pursley. We could not have had a better speaker for this topic. Thank you so very much. I think we are now at 4 o'clock and our time is up. How long do we have any more time? I don't think.
No, we meet back at 4:15 for our breakout sessions. I think Sheena's up.
Again.
Thank you, Dr. Guillory. We are going to take a 15-minute break now, but I just want everyone to know that we will now be continuing into concurrent sessions and putting the links into the chat as we speak. And so We have the information here on the slide for concurrent session 1, which is reducing maternal morbidity and mortality related to hypertensive disorders. That'll run from 4:15 to 5:45. Concurrent session 2 also starts at 4:15 and ends at 6 p.m. That will be for newborn admission temperature. So after the break, we'll be starting promptly at 4:15. Please select the link that you would like to join, and we will continue the rest of the summit there and conclude day 1 within the concurrent session for today. Thank you, everyone.